part one of this presentation, we review the staggering statistics that reveal a growing trend toward a diabetic population that will likely equal 1 out of 4 males and 1 out of 3 females. We also review the basic concepts of glucose and insulin control mechanisms, the history and review of system clusters that identify the pre-diabetic or diabetic patient, and the physical examination and lab findings that confirm that diagnosis. Now, let's move on to some of the management decisions that you and the patient need to discuss. Certainly, there is a continuum of options, including management of prediabetes with diet and exercise and repeat A1C testing to determine compliance and effect, all the way to the other end of the spectrum, simply referring the patient back to the primary care MD. In between, though, are some options that we should discuss. An important component of decision-making is the patient's acceptance that there is a problem, regardless of whether they're symptomatic or not. In other words, they must be educated and motivated. They must understand that lifestyle changes are unlikely to be permanent without the understanding and support of family and loved ones. In fact, lifestyle changes are likely doomed to failure without everyone making the decision to change. This clearly takes commitment, education, and coaching. Let's first start with what the literature says and what major guidelines recommend. The American Diabetes Association recommends lifestyle modification as the best way to prevent and delay diabetes, which should include a minimum of 30 minutes of moderate physical activity daily and loss of 5 to 10% of body weight. For those with prediabetes, loss of 6% of body weight has been shown to prevent diabetes in 58% of individuals. Components that taken together improve utilization of glucose but also result in decreased weight are dietary changes and exercise, and really both need to occur to maintain appropriate weight and therefore ward off or eliminate diabetes. Here's one large study with over 3,000 individuals followed over 3 years that involved a comparison among 3 approaches: treatment with metformin, which is a common hypoglycemic agent called glucophage, management with lifestyle modification, and no medication or placebo. Everyone was surprised by the results. The reduction in incidence of diabetes in the lifestyle group was 58%, whereas the metformin group incidence was decreased by only 31%. It is true that the research participants in the lifestyle group were quite involved. In addition to a low-carbohydrate, low-fat diet, participants engaged in physical activity of moderate intensity, such as brisk walking, for at least 150 minutes per week. They also participated in a 16-hour curriculum designed to support the changes in diet, exercise, and behavior modification. The goal was to maintain a weight reduction of at least 7% of the initial body weight. A 12-year follow-up study of over 42,000 males evaluated a comparison between 2 dietary regimens and the relative risk of type 2 diabetes. The researchers concluded that a Western dietary pattern, high in red meat, fat, refined grains, and sweets and desserts, combined with a low physical activity or obesity, substantially increased the risk of type 2 diabetes, compared to a prudent dietary pattern, one high in consumption of vegetables, fruit, fish, poultry, and whole grains. What are the general components of a diet that would improve glucose utilization? Well, much of it is not a surprise. As mentioned in the previous study, a prudent diet versus a Western diet is needed. This involves a low-fat diet comprised of primarily mono and polyunsaturated fats and a diet high in fiber and 50 to 60% complex carbohydrates. Complex carbohydrates are slowly digested, preventing a rapid rise in glucose. Of course, refined carbohydrates found in many processed foods do the opposite. Specifically, foods that improve insulin sensitivity include broccoli, cabbage, Brussels sprouts, cauliflower, green leafy vegetables, beans, legumes, vegetable proteins such as soy and peas, fiber including rice, oat bran, guar gum, and psyllium, and foods that are rich in omega-3s. The advantage of vegetable proteins is that they contain soluble fiber, which decreases the insulin response. Also, protein stimulates the production of glucagon. Soy foods also contain omega-3 fatty acids. The exchange approach is a more formalized strategy to get patients to make the right choices in food and educate them on options to accomplish the same goal of total calories and what those calories are made up of. Foods are grouped into 6 categories of starches, fruits, milk, meats, vegetables, and fats. An exchange means that foods listed in a category can be substituted for each other so that the choice contains the same number of calories and generally similar makeup of carbs, proteins, and fats. The basic currency used in this plan is a serving size of carbs, which equals 15 grams. Then, using a total calorie count for a given individual, meals are constructed which are based on selections from each category. The patient choice is to select within each category the food they want, which also has a designated serving size so that all foods within the exchange category provide the same carbs and usually other nutrients. There's also a diabetes food pyramid, which indicates suggested servings for each category of food. There's a sea of resources available online in texts, videos, through diet centers and health centers, dietitians, and hospital-based programs. Some of these resources appear on the homepage of this video. A commonly recommended approach for patients to follow is the glycemic index categorization of foods. The glycemic index refers to how quickly a consumed carbohydrate affects postprandial serum glucose levels. The value is based on a scale of 100 represented by glucose or white bread. The problem with this limited approach is that some foods with a high glycemic index are by percentage of total content low in sugar, such as watermelon, which is mainly water, and also that the portion of the food determines the total glycemic effect. The glycemic load compensates for these faults and adds in the feature of a typical serving of a given food, so that foods that may have a high glycemic index may have a smaller impact based on the glycemic load, given a more accurate measure of their glycemic effect in total based on portion size. One caution about using the glycemic index as the only approach is that each individual's response is different to different foods based on their metabolism and the combination in which the foods are eaten. The difference can be as much as 5 to 10 points, so that a difference in glycemic index between foods by this amount may make little difference. Well, this is a coffee break presentation, so we should discuss the evidence for coffee in helping to manage diabetes. Many systematic reviews have addressed the issue of whether caffeine, and specifically coffee, is harmful or beneficial. Acutely, caffeine may have negative effects. However, chronic high intake of coffee, and in some studies tea, has been shown to decrease the risk of diabetes. Other studies also have shown an inverse relationship between high coffee consumption and diabetes, up to 6 cups a day. Be careful that caffeine and coffee are not equal here, because in some studies decaf coffee also works. Coffee contains antioxidants and specifically chlorogenic acid. Another study indicates that timing may be important. This study indicated that drinking coffee at lunch had the largest benefit. You may have noticed I haven't mentioned some of the commonly recommended supplements for diabetes, including biotin, chromium, magnesium, essential fatty acids, vanadium, B-complex, vitamin C and E, and zinc. Well, yes, there's a reason. Most studies on these supplements and a number of herbs are either small or overlap with management of hyperlipidemia and atherosclerosis. It would seem prudent then to simply acquire these nutrients from natural foods first. If for some reason this appears ineffective, perhaps additional supplementation may be necessary, although probably rarely, and more often as an adjunct therapy for neuropathy. Well, let's move on to exercise. One study indicated that if diabetic patients were convinced to walk 2 hours per week, the rate of death would decrease by 1 per year for every 61 people who walked. In another study, the benefits of walking were also demonstrated with women who performed an 8-week walking program of 10,000 steps per day, with benefits of improved glucose tolerance and a reduction in blood pressure. There are many other studies showing similar results. Why does exercise work so well? Well, several factors, but primarily a changed body composition with more muscle and less fat increases the utilization of glucose. Also, there are increased levels of glucose transporter proteins and glycogen synthase. Of course, with exercise, there may be concerns about hypoglycemia because of problems with insufficient compensation for increased glucose uptake by muscle that would normally result in increased release of glucose from the liver due to increased circulating glucagon. For patients on insulin, sulfonylurea drugs, or glunides, There's often a fall in blood sugar during moderate or strenuous exercise that may last up to 12 hours. On the other hand, because of increased glucagon and catecholamines persisting after strenuous exercise, there may be hyperglycemia. Another concern is with anaerobic exercise. It should be less strenuous for patients with cardiovascular complications, and with isometric contractions, patients must remember to breathe. With isotonic weightlifting, the lift should be done on exhalation and then inhalation should occur as the muscles relax. This may avoid unnecessary elevation of blood pressure, which can also be harmful for the kidneys. For those with peripheral neuropathies, there is a risk for injuries that are not felt in the feet and toes. For all these reasons, if exercise is going to be recommended to patients already on medication, consultation with the primary care MD is important. Regardless of approach, lifestyle changes are a requirement in the prevention and management of diabetes. It's not enough to minimally challenge oneself or to start and stop efforts at change. Doing little off and on is simply rearranging the deck chairs on the Titanic. Patients who currently take medication other than insulin should be reminded that without adopting lifestyle changes in diet and exercise, they will be using insulin within years. So what's an easy way to transition into an exercise routine? Suggest to the patient a 3 times per week walking program where they simply walk 15 minutes each time. Over several weeks, encourage them to increase this approach by 5 minutes every week or so to arrive at a final goal of 30 to 45 minutes of moderate intensity aerobic activity 3 times per week. Certainly, if motivated, this could even progress further, but always remember this commitment to exercise is something that patients must be comfortable with, making this a permanent lifestyle approach. Shooting too high may be sabotaging long-term goals. Let's take a brief look at the medical management of diabetes, starting with common medication classifications and their general mechanisms of action. Sulfonylureas such as glipizide, glypuride, glimepiride close energy-sensitive potassium channels on beta cells, causing influx of calcium and subsequent release of insulin. Biguanide medications such as metformin cause primarily a hypoglycemic action based on an effect of decreasing glucose production from the liver. Thiazolidines, including Actos and Avandia, attach to nuclear receptors in cells to cause an increase in production of cellular proteins that facilitate glucose transport. In addition, because diabetes is progressive, many patients initially taking medications other than insulin, in 5 to 10 years, need insulin. What makes the management of advanced diabetes so complicated is the balance of the use of so many different medications. This is a recipe for polypharmacy's inevitable result of side effects. In addition to insulin and hypoglycemic agents, patients are likely taking pain medication, and if they have diabetic neuropathy, this may involve not only standard pain medication, but selective serotonin and norepinephrine reuptake inhibitors like duloxetine, an antidepressant, and gabapentin, an anti-seizure medication used for neuropathic pain. Because of associated hypertension and hyperlipidemia, medications for these conditions are also prescribed. For the control of diabetic nephropathy, national recommendations include a low animal-based protein diet and switching to more vegetable and soy-based proteins, combined with hypertension control using an angiotensin-converting enzyme inhibitor. For diabetic retinopathy, tight glycemic control, management of hypertension, and avoidance of smoking may help prevent the development of retinal changes. If neovascularization occurs, laser photocoagulation is sometimes effective. For diabetic neuropathy, tight glycemic control and avoidance of smoking are essential. Nutritional recommendations include vitamins B12, biotin, and inositol. A serious concern more for type 1 diabetics, but occasionally with type 2 diabetics, is ketoacidosis. With diabetes, there is a switch from aerobic glycolysis to anaerobic glycolysis, which leads to excess lactic acid formation. Combining this with inadequate utilization of fats and lipogenesis, there is an accumulation of free fatty acids which are oxidized to ketones, worsening the acidosis. Clinical clues are signs of dehydration, altered mental status, and a fruity odor to the breath caused by acetone. So now the big picture. We should screen patients through history and review systems questioning for clues to type 2 diabetes. Screen with a physical exam for neurological deficits in sensation and vibration, and for those at risk, order a full lab and include HA1C. For the pre-diabetic, there are some no-brainer, easy-to-adopt changes, such as simply walking 5 to 10 minutes a day and increasing this gradually over time. Adding a green leafy vegetable serving to most evening meals has been shown to decrease risk of type 2 diabetes by 14%. Have the patient choose 2 lunches a week and simply have 2 low-fat yogurts and fruit instead of their normal lunch. If they're willing to invest more time and energy, have them join a gym and sign up for an exercise training program, because weight loss is key with type 2 diabetes. Have them either use web resources to find healthy meal recipes or have them simply join a weight loss program. If they're entirely committed to prevention, or even for those with early type 2 diabetes, refer them to an American Diabetes Association certified diabetes self-management program. Also, network with all their contacts, including their primary care MD, to double-team the patient with constant reminders of the need to change and encouragement when they do. If the patient is pre-diabetic or diabetic, make decisions based on your practice environment, knowing that management is time-intensive. Whether the patient is referred or not, provide recommendations and encouragement for lifestyle changes, including walking, smoking cessation, and the ultimate goal of weight loss that is between 5 to 10% of starting weight. Provide educational resources to the patient and consider working with a diabetes self-management program certified by the American Diabetes Association. Given that obesity is the most important risk factor, networking with a weight loss program in your area is important, given the time and energy necessary to establish a routine that is maintained by the patient and not treated as a quick weight loss diet approach. Look at the homepage of this video for a number of valuable resources. It is our obligation as healthcare providers to do all we can to prevent and reverse the national trend toward diabetes and its consequences. Put one way, if we knew that we could prevent the death of thousands of people each year in the U.S., and the only intervention necessary was convincing those people to change their lifestyle, could we ethically accept the unintentional slow suicide of these individuals and do nothing?